Hello and welcome to the Kingdom Strength Podcast. My name is Troy Briscoe. I am your host, and at the Kingdom Strength Podcast, just to let you know, we discuss anything from Scripture, the Christian walk, strength and human performance, clinical concepts for you practicing clinicians out there, anything for athletics and coaching. We have something for you, and today is no exception. We have a guest on the show today, Dr. Gabriel Williams. Welcome, Gabe.
Thank you very much. It is an honor to be on the show and with the one and only Troy Briscoe. It's an honor.
Please. Well, hey, Gabe, thanks for being here. For your listeners out there, Gabriel is a longtime friend and brother of Christ. To me, I'm very grateful for him being on the show today. And he is obviously Dr. Chiropractic. He's also a personal trainer. He's been doing that for a very long time now. And I'm excited to hear what he has to say today. We're going to be specifically talking about patient care and some patient cases. So we're going to get some clinical insights from him today, as well as anything he has to share in terms of training and his experience there with working with clients. But there will be some great takeaways for you listeners today when it comes to working with people, working with patients, and progressing people to their goals and helping them feel and move better. So without further ado, let's get into it, shall we? So, Gabe, tell us a little bit about yourself, a little bit your background, walk with the Lord, educational experience, how long you've been working with clients and patients, things like that.
Yeah, absolutely. So we'll start with the most important thing, as I would say, is, relationship with the Lord, because that comes first. So background with that, thankfully, was blessed to grow up in a Christian home. Accepted Jesus Christ when I was about 5 years old, and I truly do believe I made that decision. Obviously, it's been a journey ever since, but made that committed decision to follow him at 5 years old.
Praise the Lord.
And grew up in the church. Again, family are all believers, and they are such an impactful, part of my journey. And it's been such a blessing looking back. Every year I get older, I just value them more and more, and for the Lord placing them in my life. And was homeschooled from second all the way up to high school, which was also just another wonderful opportunity for me to just be able to dive into the word day in, day out, first thing I do before I even get into the studies, which has changed my life forever. And if it's one thing I can recommend, which we'll get into later, it's diving into the word. I promise you it will change your life. So from there, a little educational background on me. I went to Liberty University for undergrad in Lynchburg, Virginia. That's where I went and got my bachelor's degree in exercise science. That's when I started, as Troy mentioned, my career in personal training, and then also in strength and conditioning as well. I have my CSCS from NSCA. And from there, I knew I wanted to go to grad school. I wasn't sure where I wanted to go. I was leaning towards PT school, maybe PA. Ended up stopping at a clinic that my mom was a patient at for a little over 10 years now. And it's called Carolina Sports Clinic in Charlotte, North Carolina.
Good place.
And was there for about 2 years total. Did my internship there, and then was a clinician assistant, and fell in love with the process of chiropractic. I was not sure what they did at all. Didn't know if they were kind of rack and crack.
Yeah, in bone centers.
I just knew they were doctors. That was it. Yeah. No idea. So after observing them, the PTs, they had some other therapists in there as well, fell in love with the process of how they do things, especially with such a integrative approach to multiple different systems. I decided to go to Parker University, and that's where I met the host, Troy Briscoe, and then just recently graduated from Parker.
I see you
with
repping
the doctorate in chiropractic. Oh, you know it. Got the gear on. With the doctorate of chiropractic and a master's in human strength and performance, and just recently graduated in
Yeah, you did.
December last month, and been in practice for roughly about a month. Yeah.
Yeah, he hit that ground running, getting into patient care. But Gabe, I love it. I love it. We have a similar experience too with kind of being PT track and not really knowing much about chiro before kind of getting into it. Of course, I didn't have an experience of working at a chiro clinic, but yeah, when I shadowed, I was like, wow, this is it. And prayed a lot about it, and doors kept opening. And just like anyone with the pulse, got into Parker, and the rest was history there.
A little concerning, but true.
The hard part is making it through trimester 2, the term 2
Oh,
part,
yes.
but we did that.
Easy
Piece of
part's getting in.
Yeah, yeah,
Hard
yeah.
part's getting out
Hard
of there.
part is yeah. Sticking it all the way through. Oh, man. But yeah, no, I really fell in love with the autonomy that a lot of the chiros I was seeing work, and they just have so much free reign to kind of do what the patient may need, do what they want within their scope. So it's very encouraging to see, and being portal of entry docs, sky's the limit, and you really can be creative with patient care. So that's what excites me about it. And that's, why there's a lot of good outcomes usually, but across the board, there's good and bad, pros and cons, but we won't get into that conversation today. Let's get into your experience with patient care. Gabe is a young clinician. He's been in the trenches just for what you said, about a month and a half. So tell us a little bit about your experience there with treating patients and being in the clinic.
Yeah, absolutely. I thought it was going to be a much harsher transition going from school to treatment.
Hmm.
And obviously they call it practice for a reason. And I think it will be that way until the day I retire. Is there will always be something to improve upon and learn. But
Hmm.
the transition was a lot smoother than I thought, which was quite pleasant, I will say. But again, there was so much to learn, especially when it came to communication with the patients. When it comes to treatment, I felt strong. I knew the systems I was comfortable with. Obviously, like I just said, there's always room to improve
Hmm.
in especially taking from multiple different systems. As we both have experience with RTP where we're diving over systems like ART, needling, DNS, McKenzie. Like there's so many different treatment styles and things which can help the patient. And when it comes to patient care, you're like, okay, I've got to make the decision. What can I do in this short amount of time that I have with them in
Hmm.
order to make the best change possible?
How
So
much
that's
time you
been one of
working
the
with?
biggest things. So our new patient exams at our clinic are 40 minutes, and
Hmm.
then established patients are 20 minutes.
Okay, cool.
So, and that sounds like a long time in grand scheme of things for chiro visits, but that goes by like that,
Hmm.
snap of a finger,
Yeah.
especially when they're dealing with multiple complaints or, multiple different issues or very complex cases.
Hmm.
And again, just learning to manage your time, communication, all the different systems that you have to choose from, and condensing to that, especially with the exam. With our school, we had 2 hours for an exam, which that doesn't fly
Yeah,
nowadays.
yeah. Half the battle was documentation in the EHR system there, but
Oh, exactly. So learning to condense that exam to get all the relevant information I need to figure out this case and provide the best treatment possible. And then in order to do the treatment, I need to do the hands-on portion to maybe calm things down, but then also build them something that they can take home and
hmm,
educate as well. That's
yeah.
been the biggest thing, is taking all that, condensing it into that short time period. And again, the other big thing was communication with patients, which has been so big.
Hmm. Yeah, yeah, and you're right when you say it kind of sounds like a lot, especially when people are used to kind of the more traditional chiropractor. But when you're tackling multiple approaches, using a multimodal approach, and you're trying to integrate lots of different things and make space for education with the patient throughout that time, and maybe even progressing to some loading strategies, things like that. All that takes time. So it is definitely, would fly by. I've definitely shadowed people across the board, and right now I'll be working with longer visits when I start up at the practice I'll be joining, but I'm very much looking forward to it, and I do expect it to absolutely just fly by with the time there. And also it depends on the model you're on with, if you're doing insurance or cash, or again what systems you're using. So on that topic though, tell us a little bit about the systems that you like to use as far as assessment and treatment, and what you find yourself using more at this point in your career as a young starting clinician there.
Starting assessment wise, it's nothing crazy. Depending on the case, we'll run through our orthopedic exams, neurological exams, movement screening. That usually looks more like a global movement assessment, kind of following some SFMA.
Hmm.
And so after going through that and the history, obviously, so then we'll go into some different systems. Sometimes I'll break into one huge one, which we've covered a lot in school. And I just knew it was going to be present, but I didn't know how present it was going to be, was McKenzie. And I'm not a full McKenzoid, as some would say, so I don't necessarily go through the full protocol.
I
with
haven't
that,
drunk the
but learning how
Kool-Aid
to
on that
not the full Kool-Aid. I'm bought in, don't worry.
one.
But
You can quote Brett
full
Winchester there
assessment
to
learning.
be a closet McKenzie.
Yeah, exactly. Closet McKenzie. So that is one I have used quite a bit, and that's both on the assessment and treatment side of
Mhm,
trying to find like DP, directional preference, and then also using that for treatment for take home exercises, but going through and explaining that with the patient as well for mechanics, but also, diving into some minor DNS strategies as well to facilitate tissues. Big fan of dry needling
mhm,
as well. That has been a huge part of the practice that I'm in now. I've been learning about implementing different times and different strategies for when to implement that. Sometimes that's just for, tissue health, regeneration, trying to get the body to respond to that area versus sometimes it's more neurological. We're then getting the stim with it to really try to facilitate that tissue. Turn it on like a light switch. A lot of times we use a light switch analogy with patients where the muscle's inhibited. We're trying to turn it on. Dry needling is one way we can do that, especially with the added stim to turn that muscle on, wake it up, so then we can probably use that in certain mechanics and movement patterns.
mhm.
And then with that as well, also
Yeah,
make
for
a
a
difference to
safety
the
pin.
neurological symptoms. Exactly.
Yeah, I'm just playing. Anyway,
So,
sorry, you were saying?
no, you are all good. So, yeah, so that's just a brief look at some of the different systems that we
Okay,
tend to
cool.
use over at the clinic.
I like it. McKenzie, DNS, dry needling, all very powerful. Let's take a second to talk about McKenzie a little bit. I think a lot of times it gets a bad rap because people don't quite understand when or why or how to use it. I've had a few conversations where people like to bypass it altogether or, just because it takes a while maybe to find directional preference or maybe they even just think McKenzie's just prone press ups or just chin retractions, a lot goes more into find directional preference, but like for example, I'll be in conversation with somebody and they'll call, oh yeah, I did McKenzie's and they're referring to just a prone press up. And I'm like, yeah, sure. That might be a part of it, but it's like, it's like, no, it goes a lot beyond that. Like finding directional preference could be extension. It's most often extension, but it very well could be, a lateral component or even flexion. But that's why it's so important to take a thorough history and exam. And even if it's not a McKenzie case, do your due diligence and ruling it out. And for me, as a young clinician, and if there's any young clinicians out there listening to this, like I'm going to take a pretty broad approach with my assessment. I'm going to be thorough in ruling things out, try to diagnose by exclusion there and really do my due diligence because I don't have pattern recognition accumulated yet to really effectively like figure things out like really, really quickly, right? So it's okay. It's okay to take time. It's okay to go through the process there. But anyway, you're talking about McKenzie, and yes, it is assessment, it's mechanical diagnosis and therapy there. So you're doing assessment and diagnosing, and then it's treatment as well. So it is a very potent thing to do when you're going through that first visit there to see if you can actually move the needle there. So anyway, before I just quick keep rambling on about McKenzie, tell me and the listeners about a case where you found it to be like a big component, a big McKenzie component to the case.
I know we were talking yesterday.
Mhm.
Had one yesterday come to the clinic, and it was funny. On Friday, me and some of the coworkers were doing McKenzie Part C, going through some of that material, which is extremity and advanced lumbar. And that was nice because I haven't done Part A since probably 2023, I believe. So it was
Yeah, I
good
remember that.
refresher going through that because, as Troy just got finished mentioning, McKenzie is not just your prone press ups or chin retraction. It is a whole system that can appear in so many different ways. And obviously, yes, the main component is finding that DP or directional preference, which the patient responds to. But it's not just extension. Is it most of the time extension? Yes, but it's not only limited to extension. And you will see that come into the clinic a lot of the times. So the one yesterday I had was just textbook McKenzie case, where the only thing they were missing was maybe some radiating symptoms down the leg. He did not have any radicular symptoms, no numbness, burning, tingling. But when he came in, said just band across the low back. It went into his left SI joint just a little bit, kind of into his left hip. Didn't wrap around the front. He had no or very minor mild pain. He said it was around like a 2 or 3 when he was kind of just walking, moving around, sitting upright. But anytime he sat in a kind of a slumped position, it would flare it up. Anytime he would bend forward, it would flare it up. Kind of textbook McKenzie in terms of what you'll see most of the time is a posterior derangement. Usually it will be posterior lateral derangements that we'll see. So his was textbook, and the fact that immediately when we got into the assessment and had him going into some standing and range extensions, immediately felt better during the motion. And McKenzie, they have different classifications where they'll have their red light, yellow light, green light going in there. And then for him, it got better during, but didn't change after. The pain didn't change, pain presentation didn't change. The only thing that did change was he was able to flex forward more freely now. So
Okay.
he was able to get another 10 to 15% more flexion for doing the standing.
That's a win.
So yes, we love those wins. We
Mhm.
take the minor wins and went into force progression. So had him end up going prone press ups next, and he responded even better. Sorry, went into
Sustained?
sustained extension, and he said he was fine in the position, but getting out of position felt a little sticky. He
Mhm.
didn't like that too
How's it?
much. Kept going with force progression, went into prone press ups, and as he was doing the prone press ups, I said, make sure to keep track and keep me updated on how pain presentation. Is it going down the leg? And was explaining that maybe like some peripheralization. Is those pain symptoms traveling further down, whether that be that numbness, burning, tingling, a dull achy pain traveling further into the hip, into the leg, or is it centralizing, we'll call, where it's moving out of the hip or out of the leg into the back and becoming more central? So as I was describing that, I said, after about the fifth or sixth rep, I said, has that pain changed yet? And he kind of gave me a confused look. He kind of turned and was like, yeah, it's not on the left side anymore. He's like, you're right. It's all in the middle. Just all the pain's just right in the middle of my back now. I was like, wow, just from 5 or 6 movements like that, we just had immediate centralization, which I will say you will not get all the time. Sometimes it will be a lot more stubborn cases, but
Mhm.
it was cool to see the system respond, so fast and so well and get immediate centralization with that. And then went on again to clinician overpressure. So went to the next force progression. The clinician overpressure during the movement again felt better and better. And then it was about the same results from the regular press ups to the clinician overpressure. Had him get up, walk around, retest flexion, and then he was able to get, I'd say 50, 60% more flexion with that. And pain stayed centralized. So
Mhm.
that was just one example of a like textbook
Mhm.
McKenzie case where it just happened immediately like that with
Yeah.
that system.
Yeah, dude, I think that's a great case to talk about, especially if we're on the topic of McKinsey and say any listeners want to, potentially learn more about it and getting introduced to something that is pretty straightforward and a classic case. While we're on the topic of McKinsey, I'm a fan of it. You're a fan of it, of course. With it has its limits, but I think it's worth talking about so people can be equipped to utilize it, right? So briefly, let's kind of close out McKinsey conversations just by educating a little bit on it. So you used the term derangement, things like that. Could you briefly describe what a derangement is?
McKenzie's derangement's a little bit of a unique presentation of how they describe that. So usually that'll be kind of any classification of, we're usually talking about discs, and they had different theories. McKenzie, they don't exactly know what's going on. And frankly, they don't really care because the clinician outcomes and the outcomes of treatment is so well documented, so well researched. And if you actually do find DP, the prospect of getting better is so high. And there's so much research about that, but we don't know exactly what's going on when it comes to the tissue. You'll hear some with like the jelly donut theory, where the disc material is being pushed, that you have the nucleus pulposus and you have the annulus fibrosus around it. And that nucleus pulposus is being pushed in one direction. And the theory is, we're sitting all day, we're flexing all over, or flexing, bending down, picking things up, or driving. We're always in a flex position, which can put compression, flexion compression on the front part of the disc, which is pushing the material back. And then by going into press ups in this case with a posterior lateral, by going into that extension, you're theoretically pushing the material back in. That's one theory that you'll often hear. Is that exactly what's going on? Unfortunately, we don't know the answer yet, but we do see such great results with it. But going into directional preference would be the movement that gets the patient out of pain or centralizes them. We're really looking for centralization. That's the biggest thing we're looking for. And again, that's taking those symptoms from distally to proximally out of the leg, out of the hip, back midline to the spine. So we're looking for directional preference. Most of the time, that tends to be extension. Next, we'll usually get flexion. And then the least common we'll see is flexion. But how we do that is usually we'll just go through a set protocol. Most people start standing. Sometimes, depending on the case, you will have to switch that presentation. Sometimes, like I was saying, how I started with this past patient was standing in extension, kind of knowing his history. I already kind of put together that that would be the DP for him. But sometimes you'll have some where it's a little bit more tricky to find out, and you may have to extend them, 10, 15, 20 reps to figure it out, flex them, or do lateral side glides. So it really depends on the person, and then taking the time, as you said, it's just so important that you have time and make sure to take that time to really try to figure out their directional preference to hopefully get to some centralization.
Mm-hmm.
And what we're looking for is you also get, as I was saying earlier, peripheralization. That's what we're trying to avoid, is those symptoms going farther into the leg or intensifying.
Mm-hmm. Nice. I think it's a very, very solid explanation. And I just to add on to the concept of kind of the mindset of McKenzie and even the shift in the profession and field as a whole to kind of step away from the pathoanatomical approach and to just to kind of look at functional outcomes, I think there's a big shift in that direction, which I quite frankly agree with. To some extent, there needs to be some subjectivity measures so the patient can understand, hey, I am getting better, because they may care more about their pain than functional outcomes, but that's where education comes in, right? So again, that can be a topic for another day. But that being said, though, I happen to enjoy nerding out about the mechanisms at play, and while we do not know, it's cool to talk about. So whether that's the disc theory, which many McKenzoids probably still subscribe to that from my dialogue with them, and again, whether it's that or, like Cody DeMac, he's a big proponent of the vasonervorum, and the in-range repetitive loading kind of pumps the blood and kind of the pain. The theory is there's a pooling of the blood causing irritation and sensitivity to the nerve that supplies the nerve. So that's causing pain, and the repetitive loading kind of pumps the blood out, so decreasing almost that ischemic compression there on the nerve itself. Or kind of what I think is going on more times than not is actual like joint receptors, like the type 3 joint receptors within the joint. When you get to in range, those are stimulated and can have a bit of an analgesic effect to calm down pain a little bit and increase range of motion as well. So when we talk about derangement, that's the most common classification within McKenzie. And derangements, what's present? There's an obstruction to movement. Pain is variable; it kind of dances around. That's kind of a classic presentation of it. When you're palpating and find a joint restriction, getting to in range, moving it around, see what the functional and pain outcomes are, and see if you're moving the needle. It's to me, really effective way to kind of move the needle on your pain or functional audits, and seems to be really effective from the times I've used it. And so it's cool to hear a case where you're seeing some good outcomes with it as well. So anyway, it's neat to discuss the mechanisms. I don't know if anyone out there is also a nerd about it. I know, like I mentioned, Cody DeMac, one of our mentors at Parker University, is. So it's been fun to learn from him about his thoughts about it all. And if anybody at Carolina Sports Clinic is particularly interested in it, but
Everyone loves it.
but anyway, so I think we did a thorough job discussing McKenzie. The listeners may be kind of ready for us to move on from that conversation. So a natural progression in my mind when it comes to actual application in McKenzie, say you desensitize the pain with repetitive in-range loading or sustained loading in your case there. then they have that tool to do whenever, they're out and about and maybe pain comes about. They know they have something that can decrease their pain. And again, we don't know the specifics as to why that might be the case, but hey, at that point, the first phase in the rehab process there is to desensitize the pain. So once we're at that stage in the treatment plan, okay, they're feeling better. What comes next? What comes after the application of McKenzie or finding directional preference and utilizing the repetitive or sustained and range? Let's hear your thoughts on that.
Absolutely. And that's going to be one that's a little bit case specific. But to give some examples, you're going to find a lot of that information in the assessment as well that you're doing along with McKenzie, trying to find like the root cause of why this may have started. And a lot of times, the why, exactly. So, like you said, McKenzie is a tool to desensitize. So, once we decrease pain, now we need to increase function. So, for some patients, that's movement patterns. That's movement patterns and posture, which may be adding more pressure, like we were talking about before, that flexion compression component to that, to that disc or to those structures that could be causing the pain. And then giving them tools in order to, in their daily life, in the gym, whatever may be putting most of that compression in those or on that disc or to those structures, by being able to give them ways to be able to decompress or take them off, whether that be movement mechanics, by teaching them how to hip hinge. A lot of patients don't know how to hip hinge. They're using their back in a flex position. And then making sure to check deficits, especially when it comes to back, core, and hip stability too. Because the core is not just, you know, the back and the abs. You have to check the hips as well. A lot of times we have muscles, like I'm sure you have seen time and time and time again, do a glute med or a Yanda's test, and that thing is asleep, not working at all. And obviously, if glutes aren't working or if core's not working, what is working then? That means the erectors, that means the back is going to be taking more of the load than it should be. So making sure, doing the assessment and figuring out, okay, are all the tissues that need to be supporting the back, are they actually facilitated? And if not, okay, we need to start giving them what they need based off of our assessment in order to increase that function, whether that be more core stability, whether that be more hip stability, whether that be more posture and, biomechanics and movement patterns to help avoid some of those movement patterns. And then lastly, with McKenzie too, which I feel like is a big thing, and just overall assessment, is in this case that I'm dealing with, flexion is the aggravating factor. And for right now, while we're in the very acute stage and decreasing pain, obviously we want to be able to reintroduce flexion. So that will be something that will gradually come into play into treatment. And a lot of times I'll kind of sneak that in with core. I'll add some core flexion things in there, even like a dead bug in there as well, where they're in a just slightly more flex position with that while they are still avoiding extension in the end range position of that. But just adding some ways of reintroducing flexion slowly, because obviously we can't avoid flexion. Flexion is going to be something that is in our daily lives. So slowly reintroducing them to that movement pattern and then strengthening them in that movement pattern. So
Hmm.
their load capacity is at a much higher level than it was before they entered your office to avoid re-injury later down the road.
Hmm. I love that. Yeah, no, I think that is a great thing to talk about after like a discussion like we had on McKinsey with the story doesn't end there. There's a reason why we're experiencing that pain. There are some functional deficits somewhere, like the tissue is sensitive for a reason, and general capacity work is great too. But I like how you said matching the exercise and the progressions to their directional preference because that's obviously a direction that helped as far as in range loading. So it's not a provocative movement, so you can kind of start with forces in that direction, and whether that's central or core work, it's a great way to kind of start off with building that strength and capacity of the trunk. And starting with the forces, say it's extension, you can bias extension when you're doing some core work, or if you're starting with core work, it is nice to kind of keep it, you know, the rib cage and the pelvic floor, aligned so you can build that intra-abdominal pressure. Now we're kind of getting into a DNS conversation, but that is where the McKenzie, the DNS, and loading strategies like come together. That point between pain is desensitized, you're being sure they have a solid foundation with trunk stability, and from that stability they can progress into more functional or compound movements, whatever their goal may be, right? Getting them to where their goals are with what they're trying to work toward. But very simply put, with the conversation we're having, with that progression of forces, similar to how you're talking about with McKenzie, there's progression of forces to really get to in range. We can progress forces within our loading as well. So starting with something that isn't provocative, that biases their directional preference, and then getting back to the formally provocative movements. So started biasing forces in that direction. So flexion, for example, to build that capacity that was formally deficient, formally provocative, to where they're by the end of the treatment plan, they're back and stronger than ever, ready to take on whatever they want to do in life. So I think that was a great way to put it and explain it. And we don't want people to be scared of any particular movement, right? Like I'm working with a client right now who is, mentioned potential fear of avoidance with deadlifts, and so it's out there. People kind of have preconceived notions, and say they are doing it. Maybe it's a thought in their mind that may actually cause the presentation of pain, getting more into like a central sensitization kind of thing, or affective pain mechanism, where the psyche, or what's in your mind, is really causing you to have an increased threat to what forces you're actually putting yourself through, when it's actually totally fine, totally okay to do, and your tissues may have the capacity to do so. So anyway, that's an educational topic too with the patient. But anyway, wow, I'm rambling on. You're the guest on the show, and I'm just
You brought
cranking.
up something so important about that fear avoidance because you will say it day in, day out when you are dealing with
Yeah.
injuries. Day in, day out, especially when you're dealing with your athletes too.
Heck yeah. So wanted to navigate a little bit into a discussion on your experience with personal training, and how that has blended with your role as a chiropractor, and what that looks like now for you as well, with working with patients, and if you're currently working with clients, and how that background also shapes the way you view patient care.
If you're someone watching this who's looking to go into the health and wellness field, especially PT, chiropractic, I'd say even like PA and that, I would highly recommend looking into some personal training or strength conditioning before you even get into there because it builds such core key foundations as you as a future clinician that looking back makes such the world of difference. For example, learning to work with a patient one-on-one because that's such a big component of what we do day in and day out with all these different patients coming in who have all different walks of life, all different BPS, biopsychosocial factors. And a personal trainer, you're usually spending at least an hour with them. And then they're coming in at least one time, sometimes 3 times a week, and you're learning to build that one-on-one connection with them, which is so important. Again, not just physically, but also emotionally, and for our case, spiritually too. And then by building those things, that's what a lot of time is really getting a patient better, whether it's for pain, for function, or for mental health too. Some of them really just need,
Need to
that
talk.
mental side of things, need
Yeah,
to talk, let things off their chest. So that's such a important skill set that you learn from
I
training. And
agree.
then also learning and picking up on movement patterns and figuring out how people move in, like we were talking about before, with core stability and learning how to build that, you know, biomechanics, hip hinging, all these different movement patterns, which when you're first starting, you can barely tell the difference. You're like, that person is moving the same as them. But the more and more and more you do it, the more you start to realize, the differences of how everybody moves and then how certain mechanics might be impacting their everyday life and so on and so on. So I feel like it has drastically, improved my experience as a clinician versus if I didn't train in the past. And then as of training now, yeah, I'm working with a couple clients now, and it's really in the capacity. Most of the ones I'm working with is the transition from rehab to performance. So once we kind of get them out of the pain side with the chiropractor hat on, and we're decreasing pain as we talked about before, we've gotten pain mostly out of the picture, or you know, improve function to the point where we need it to be, where they can really start transitioning now, especially again on whether that be for the athletes who are trying to return to sport to the full capacity, or for just your weekend warrior who is still afraid to move in some movement patterns. They're still afraid to flex because, they've had this injury that's been resolved maybe for 2, 3 weeks now, but they're still scared because they have that fear avoidance, or they don't have the movement mechanics yet, or don't know how to move their body in order to, put less stress on these structures. So that's most of the people I work with. And then I'll put on the strength and conditioning hat. And then we're working on building that function, those movement patterns, that strength. And then we'll dive into some other topics like the nutrition as well. And a lot of times you were talking before is that fear avoidance. The one athlete I was working with, she had back-to-back ankle sprains. And after two in a row within 3 weeks, she was scared to really load it. Even though we got pain down, pain was abolished. No pain, even with plyometrics, return to sport protocol, she's cleared. Still, you could tell wasn't able to fully load the ankle mentally, mostly. Like the strength was there, but mentally wasn't. So creating fun ways, even like gamification, doing some reflex drills. I would have her drop off of a depth box, and in the air, I would call out either stay, jump left, jump right, jump forward, and give different calls. So, and get her used to getting her out of her head, being like, oh, okay, I'm about to
Mhm.
land on the bad ankle. And instead being like, oh, I've got to focus on what he's giving me,
Mhm.
with the
Change
call
the
in the
focus
air
of
to
attention there.
respond.
Mhm.
What was that?
I said just, changing up the focus of attention there. I think it's a good strategy for sure. Do you find that helps, in situations like that? Or do you have, other strategies you like to implement when it comes to people that may expose or may be experiencing, like, fear avoidance behavior?
Just creating some different ways like that to get them out of their head. So change the focus of attention, but then also gradually just introducing them to, in the case we were talking about before, like flexion or whatever movement that they were scared to do, just
Mhm.
gradually, slowly, increasing the difficulty on whatever that movement pattern may be.
Nice. Yeah, that's the slow progression, be like, "Hey, this is something you can do," and probably the objective test or measurements, functional audits, whatever you want to call them, really reminding them like, "Hey, you were here, now you're here. You are able to do this. The data, the numbers are telling us you have the capacity to do so. So there's nothing to be afraid of." And I think that reassurance can be helpful as well. But yeah, no, I definitely love what you're talking about with kind of making things reactionary, getting their mind off of the formerly injured tissue. You know, say someone does get injured, the odds of them getting that same injury again will increase after experiencing it. Like for example, like ankle sprains, things like that. The incidence is higher after you experience that once. So whether that's like a tissue laxity situation or like a mental situation or a combo of both. But there definitely are strategies that you just mentioned that can certainly help in situations like that. So thank you for sharing. Thank you for sharing that. Any other thoughts when it comes to kind of that transition from treatment room to training floor?
Yeah, absolutely. I'd say it's, especially as you as a clinician, it's so important that to have that conversation with patients before treatment even gets started. Because a
Mm-hmm.
lot of times you'll have a patient come in and all they can think about is pain. And you get rid of their pain sometimes in 1 or 2 visits. It's not always like that, but sometimes you do, and they disappear and they're gone. And you're like,
They say bye.
did they get better? Did they get worse? Did they dislike treatment? Like, you don't know. And then they come back and be like, oh, doc, they come back like 3 months later and like, oh, doc, you fixed me. Like, I had no pain, but now I have, same issue again or another issue. And a lot of times it's that same issue again. I had another flare up, and I've had that. And I was like, okay, I need to get better at making sure I preface with the conversation before. It's like, just because we have pain down doesn't mean we necessarily need to stop treatment, because now we need to start working on increasing the function. So then this doesn't happen again, because
Mm-hmm.
load management is such a big conversation with patients, is because most people's load management, if they're continually getting injured, or their load threshold is going to be fairly low.
Mm-hmm.
So for example, like runner. We'll use a runner for an example. And if they're just continually coming in with back or knee pain or whatever it may be, and they just keep running the same distances, it's like we definitely have a low threshold issue here. And it's like, okay, I can keep getting rid of your pain with all these episodes, but we need to figure out what's called. And then we need to focus on building strength and a load tolerance so then we can higher that load threshold so then they're not repeatedly getting injured just again and again and again. And having this conversation with patients being like, okay, when we get rid of pain, which usually we can get rid of in a few sessions, we need to transition to increasing function,
Mhm.
building strength, and increasing that load threshold for you so this doesn't keep happening again and again and again.
Yeah, that's huge. Very important conversation, and you know, I'm a little bit biased toward that too. Like patients that I see, I want to get them to that to be sure they're able to handle the demands that their sport or their hobby, whatever it is, whatever the activity of choice is, that they're able to handle the demands of that. So, very like last touch point on this conversation, when it comes to that load management, I mean, obviously the time in the visit with the patient is a great way to educate and to have a session where you're directly tackling the tissue capacity and building strength there. How do you go about handling that outside of the treatment room, like outside of their time with you? What kind of education do you give or strategies do you give them or exercises or dosage that you may prescribe? Like, are you giving exercises to patients? Is that a common thing you do? And just kind of how do you go about the delivery of that prescription of the exercise? And how do you go about that conversation when you're telling them what to do kind of outside the visit? Because it is important to kind of have those touch points throughout the week, especially if you're trying to build adaptations with the tissue capacity there. So anyway, just briefly thoughts on that, and we'll continue after that.
So one point I like to bring out when I'm having, patient discussion within the first couple of visits, or I'd say the first visit, is this is a team effort. It's like I can't fix your problem 100%. I'm really good at calming things down, but I need this to be a team effort of when you leave here that you're doing the homework, the exercises that we're going to go over, because that's where we're really going to start to make some of those adaptations that you're talking about when it comes to building up the strength of that tissue and reducing the pain. So that's that conversation we have to have with that patient being like, I can't do this all just within the span of the 20-minute visit that I have. Again, I'm going to be really good at calming things down, but in order to strengthen the tissue and make a real change, you also have to be doing your part at home too.
Mhm,
So what we do here, or what I usually do, is we'll go through the normal treatment with all, modalities, soft tissue adjustment, whatever the treatment may be. And then towards the end, I like to save time. And then I'll go over the exercises with them, make sure they're confident and comfortable with those exercises that I feel like are going to be appropriate for their case. And then
mhm,
I'll send them home with those exercises with
gotcha.
whatever sets, reps that may be, and
Mhm,
then check in next time and make sure every time I have someone come in with exercises, one of the first questions I ask is like, okay, how are exercises going? They better, they same, they worse? Give me some info because that just gives me more information on how things are progressing. If I need to pivot, if I need to change, if we need to progress, if we need to regress. And so making sure to have those consistent conversations with them and making sure they're staying on top of their rehab is so important. And some people, if you know they're not going to be on top of it, that's where a conversation is like, hey, maybe we go into training with me one on one, and then we'll switch kind of hats and we're doing more of the personal training strength coaching
mhm,
because you don't feel comfortable doing it your own or you're not doing it, then let's have that conversation and maybe we'll spend some more time doing that. Or if you're a clinician that doesn't do that, it's like, hey, I know a really good trainer, I know a really good strength coach that let me get you in communication with so we can start working on these things so we
mhm,
can actually start making a difference. And then I'll make sure to be in communication with them because I know we're still dealing with an injury here. So now you can be in communication with the coach, the trainer, whoever it is, and being like, okay, they've got X, Y, and Z issue, we can modify the plan here, here, and here. Especially if the trainer doesn't know, it's like, should I not be having them do these movements or should I? You can go in as the clinician who's managing that patient and work with that trainer and then kind of modify that plan and make
mhm,
sure they're actually getting the work that they need to make that true change.
mhm. I like that. That's huge. Building that team behind the patient, especially if they are already working with a trainer or a coach, being able to work with that trainer and coach to see what their program looks like, and being able to make those modifications if that's something they're open to. And it's all about the patient. It all comes from caring about your patient, their client, and their best interest. And it definitely, it being a collaborative effort is huge. So I like how you led with the partnership with the patient, because certainly that is very true. It is a partnership. It's not one sided. Yeah, it may be a little bit more passive when it comes to the desensitization portion of things, but when that's over, it takes work. It takes work on the patient's end to get to help them get them where they want to be, right? So it's lots of dialogue, lots of education, and a fun journey along the way. So thank you, Gabe. I appreciate your thoughts on that, and I'm very encouraged by the work you're doing. You're helping so many people out, and it fires me up to hear, man. So before we close out today, what are your parting thoughts for our listeners? What is one thing you want them to leave with today? It could be anything.
Yeah, we didn't really get to touch on it too much. Circling back to the very, 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 very beginning of that intro, most important thing is obviously in schools when we kind of go through we talk about that BPS, the biopsychosocial. But I'll either switch out that S for social and kind of throw that in with um, the P and change that for spiritual, or add an extra S, whatever you wanted to do.
Mm-hmm.
At the end of the day, I'm not the one doing all the healing.
Mm-hmm.
It's not me. There's only one doing the healing, and that's Jesus. He's the one truly making a change in these people's lives. And for me, take a step back and realize that and make sure to address that, have those conversations, like not be ashamed of the gospel when those patients come in, to be able to have those conversations. And you can just tell such a difference when you have those conversations and actually get to encourage them, push them towards Christ or whatever their situation be, but you not being afraid to bring those things up. It makes such a world of difference, not only in their lives, but also in yours. As you let your light shine, you know, it will absolutely bless, you and them in terms of treatment. And again, he's the one doing the healing. So don't be afraid to pray with the patients too. That has been one of the biggest factors in treatment, and then one of the biggest joys that I've had, how you can really touch a life. Because obviously we know we can do it with our hands in terms of physical, but again, touching them spiritually as well, not being afraid to stop and pray with them. Because you got to think, a lot of these patients are coming in and everybody's going through something, and we don't know what that is. Some will share, some won't, but they're going through something, and you taking the time to one, listen to them, to truly listen. Because most of the time you go into a doctor's office getting the bare minimum of what they need, and they're on.
Mm-hmm.
It's go, 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 go. The doctor's usually driving the conversation. How rare is it for you to go in and the doctor is truly listening to what you have to say, not just about your complaint, but what's going on in your life?
Exactly.
And a lot of times that's more healing than what you could ever do.
Mm-hmm. Facts right there, man. What a beautiful parting thought. And I love it. The BPSS model.
Patenting that.
The Gabriel Williams model. Just kidding. Just kidding. But I love it, man. I love it. Thank you for your time. Thank you for your insight. It was very beneficial to hear and discuss with you, and I hope and pray it's beneficial for the listeners as well. But like I said earlier, very encouraged by you and the brother you are to me, and the work you're doing in the field, and the way you're encouraging others toward Christ Jesus and acknowledging Him in all that you do. Because it truly is Jesus healing, and we get to be His vessels, His humble vessels, and that's what it's about. That is what it's about. So that'll end today's episode. Thank you for tuning in, all you listeners out there. And Gabriel, thank you again for being here. Much love and God bless.
Have a blessed day.